Hey all, this is going to be a intro video to the Hamilton T-1 ventilator. Um, Very similar as far as functionality goes for the most part compared to the other Hamilton vents we've gone over in the lab. There's some subtle little differences. The circuitry is a little bit different, at least the circuit I'm going to show you here that we're going to primarily use for transports and things like that. So just going to kind of walk you through how to assemble a circuit, how to fire this ventilator up, and how to do a couple of things and some of the a little bit of different things you'll encounter as you actually start using this to ventilate a patient. So a lot of our clinical partners use the T1 as a transport ventilator, be it great for an emergency room type ventilator, great for non-invasive all the way up through your invasive patients. Very, very transportable. There's a little set screw. I got this on our transport stand. There's a knob down here that I can kind of unscrew. I can actually take this thing off. It's fairly lightweight. It's got a little clip on the back or these hangers where I could mount it onto a bed or a rail or something. More often than not, for what we do as RTs, probably going to leave it on this stand. Lock this back in place here. You can't see in the video, but there is a spot for a tank to be strapped in on the back. Let's talk about our power sources. This does have two built-in swappable internal batteries, and I'll kind of show you how to access that. It's a big difference between the T1 and the C1. Still have the typical wall power. I'm plug into the red. It's going to make sure my batteries are charged up, or if anything bad does happen to my batteries, we're still good to go. You'll notice that this over here on our vents, gas source connections, only the 50 psi medical oxygen. This thing is going to have that big kind of turbine or big super fan, if you want to think about it like that, pulling in and filtering room air to contribute to the room air component. So that's nice, obviously, for transport. It's great for what we do in the classroom and the lab because I can use this and I can actually turn it on 21%, and I can use this without any medical gas. So I use this a lot for doing my demos and things like that. Not that it'd probably be too relevant for us, but if weird things do arise, there is a low pressure oxygen option on this. You'd have to turn it on. You have to make another little attachment here, and you would lose the digital blender ability, but you could actually bleed in oxygen. So if you're working in an alternative care area or something like that for whatever reason, that could be something that is useful for you. I'm going to go ahead and pop this into a 50 psi source. So let's go to the front here. On the front, this little pull-down piece, that would be where your batteries are. And the batteries have a very, very long life, but if you need to swap those out, it is very easily to access. It's got just a little magnetic cover, pops right back in place. Let's come to this side. So we're going to talk about the circuitry and some of the attachments we have to make. I'm going to just kind of show you some additional stuff that this ventilator has. If you bought Hamilton's mainstream CO2 or volumetric capnography edition, which we do have here in the lab, pop in right here. You also have a COM port, so you could link this up to like if your alarms to be transmitted or data to be transmitted out. You also can link this up to a nurse call system, so if an event's alarm's going off, somebody gets notification. Let's talk about our hookups here. So this vent is a little different than our G5. It's pretty similar to C3. We need to talk about the exhalation mechanism here, and then I'm going to show you how to kind of put this circuit on we're going to talk about. So you can call this an exhalation mechanism. I still kind of call it like an expiratory cage. You could refer to it as expiratory valve, although it's kind of missing some pieces and be a little misleading here. So this piece, this particular one I'm showing you here, would be a reusable, meaning we'd have to sterilize it between patient use. Both parts of this, okay, so this is like the plastic housing that's going to have this, which is very, very important, a weighted exhalation diaphragm. This piece seats on top of that. You'll notice that weight side is always going to be kind of facing the ventilator when we put it in, and on the T1, we have this little notch right here. It needs to correspond with that little notch, all right? And we're going to seat this on. So this is itself, once that diaphragm is installed, this is the whole exhalation mechanism for the Hamilton. Once again, this is a reusable, and I'll show you a disposable one here in a moment. All right, so this enables the ventilator to seal the system when we're trying to deliver gas to the patient. It also allows us to maintain precise levels of PEEP and things and such like that. That little metal right there. Ultimately, there's going to be contact made on this to close that exhalatory valve when we're trying to deliver gas to the patient. In between breaths, it's going to keep enough appropriate tension on that exhalation valve, combined with the bias flow to maintain our levels of PEEP. Our connection is going to hook up right here, and then this bigger port is not a standard respiratory fitting. That is essentially the exhaust port, where all that gas is going to be exhaled in the ambient atmosphere. So this piece is just going to twist and lock. We're going to go right here. You can see it says exhaust down here. There's a picture of a head with an arrow coming out, so clearly the expiratory side, and it's the only place where this thing's going to fit. So I'm just going to go ahead and slide this in place. And this is going to just clockwise turn to lock in place. If you have a little bit of trouble and it's not going, sometimes you just have to turn it counterclockwise until you feel it kind of set into those grooves, and then click and lock. All right, very, very important that you have this in properly, and you also have the exhalation diaphragm properly seated and you're using the right one. Otherwise, this ventilator is not going to work the way we need it to, and you're going to have some serious problems. As long as you're doing your pre-use check, which I'll show you how to do, you'd be well aware of any problems, but just keep in mind if you're having issues, a lot of times I always question, did somebody put this in correctly? If you see some of these more of like a clear plastic type exhalation mechanisms, these obviously you can tell because of the little dash right there, or a little cutout. These are also compatible with the C1 or T1. These are the disposable, so single patient use. You can see this one, I have a relatively large exhaust port. That'd be typical for an adult. If you're going, infant, neo type size and everything, there's a special one for those types of patients. This typical one would be good for adult pediatric patients and things like that. So what do we need to make as far as our other connections here? So as you guys know, I'm big on double filtering, meaning filtering the inspiratory side and then absolutely filtering the expiratory side as well. So I just got a simple bacterial viral filter here. Go ahead. If you look, there's a picture of a head with an arrow. That is going to be our inspiratory. Expiratory bacteria filter is going to go there. With the particular circuit I'm going to show you for transport that looks like a single limb, but it's reality a dual limb. You really need to have a filter on both to be able to make these connections. If you're running a standard, dual limb circuit, technically you get by without it. I just always filter to make sure the gas going to the patient is filtered, and then of course the expiratory side, because all that exhaled gas is coming right out down here through the exhaust. Always, always, always have a filter on there. You might even have a more heavy-duty filter type situation. So what's next? So we could hook up a standard dual limb circuit, and once again, their ventilators, Hamilton vents, are dual limb ventilators. All right, so there's some serious benefit to the dual limb. We're getting much more precise values. I feel like these dual limb ventilators have a lot of advantages over your single limb circuits and things like that. But the problem is the dual limb for transport, one more thing to kind of get hung up. And we're all used to transporting with the dual limb, and there's no problems with that. We can work around. But I like this. It's a transport circuit. It's a dry circuit, so non-heated wire, so we use passive humidity with an HME. And it looks like a single limb, so it's single limb for simplicity and not getting hung up on things, but it's actually a circuit inside of a circuit. So if you look really closely, I don't know if you're going to be able to read that. It says inspiratory. You can see there's a little blue circuit inside of this clear circuit. That's going to carry gas to the patient. And then this other part, exhalation is going to take place through this bigger appearing clear circuit, but it's actually going around the inspiratory and coming out through the side right here. So for us to be able to make these connections, we're going to need a couple of special pieces of plastic to make that work here. So I'm going to go ahead and put these on. We have it sabotaged and taken fully apart for you guys to practice here in lab, but generally these pieces would be on and in place. So I got two little white elbows here. Once again, inspiratory and expiratory. So I want to make sure that I got these correctly oriented. So I got my expiratory right here. Inspiratory right there. Sometimes you might have to tweak these little elbows a little bit if things don't want to slide in place. Kind of put it on nice and firm. Okay, and we'd be good to go right there. All right, that would be okay for our circuit. We got to add on a flow sensor and talk about humidification here though. So, as already mentioned, the Hamilton vents are the only ones that are routinely using a proximal flow sensor for invasive and non-invasive ventilation and such. Most of the other ventilators and flow sensors is going to be happening on the expiratory side as the air goes back to the vent. So our flow sensor, disposable, All right, going to go right there. I've used the circuit pretty hard. Usually there's a bunch of clips. I'd recommend locking that, your flow sensor around the circuit, especially if we're going on a transport, not just staying here in the lab, just because that flow sensor, if it's just cords are all over the place and everything and it's unhinged, you're more likely to get a big tangle and get something disconnected. So slip fit functions, I'm going to save this piece, right? That's what I'm going to need to do this pre-use check. Blue and the kind of off colored here, my flow sensor connections are going to take place right here. So there's a little picture of a flow sensor. You got a blue nipple and then like a white one. Blue goes to blue. Clear goes to the uncolored nipple there. We got our flow sensor. Okay, once again, if you had the little clips, make sure you're kind of clipping that onto the circuit. I just kind of got it crudely wrapped here. Don't overlook humidification. So if we're using this for a patient for a longer period of time, or we're doing high flow oxygen, or non-invasive, you want to add on a little bit of humidification, something like that, there is a heater bracket on the front of this, compatible with Hamilton's heater system, or Fisher-Paykel. It's got a standard heater bracket on the front, and you can do heated wire circuit with this. We're doing just this transport circuit here, so passive humidification. Technically, you'll see people say one of two ways as far as where to put that flow sensor. Their flow sensors hold up to condensation and mucus and all sorts of stuff, but I'm still a little leery. Whenever I can, I'll typically try and put the HME between the patient and the flow sensor here. It gives me an extra little bit of protection if something bad happens. I've had people that go, well, you want that flow sensor closest to the patient, which I wouldn't refute, and people will hook it up like this. That's fine too, but just keep in mind most ventilators, their flow sensors all the way back on the expiratory side. So even here, and having that HME between the patient and your flow sensor, it's still fine in my opinion. That's how I've kind of run these, okay? But just realize there's two kind of matters of opinion on that one. And then what else would we have? Well, we probably have some sort of an inline suction system, at least at the hospital side of things. So I'm going to just use an elbow here to make that, but you can once again hook up your inline suction. This is for a tracheostomy tube, so a little short, something like that, and then that would be going to our patient's trach, or if you want to put the short one to an ET tube, but you got the general idea. I'm going to just use this simple little swivel here without the suction for our purposes. Kind of spin this thing around here. Let me try and get out of that glare. Yeah, maybe. All right, power. I'm going to kind of drape this circuit up here. Power button is on the front. Press it. It's going to fire up. It's going to take a second. Take a coffee break. I'm going to try and zoom in a little bit more on this. My head's going to get cut off a little bit. It's okay. Fire it up here. Okay. That glare is gonna. All right, let me. Okay. So I need to replace a battery. I also need to calibrate my O2 cell. I got a real oxygen on, so we're going to walk through the pre-use check. Just kind of point out a couple of things here. This is very similar to all the Hamilton platforms, right? This is, I call it kind of your home screen. Whenever you turn the ventilator on or you're in a standby state, you're going to come up to these options. You can see the current mode selection up here, so you can change the defaults. You can get into the back panel and change a lot of things in the configuration tabs to what you want your vent to start at. You can also set up different profiles. So if I was an educator at a hospital, you could have like trauma profile, pediatric profile, something like that. You could have different core settings, and you could just have some generic type stuff that's different for different situations. Not necessary, but it does give you that option there. Likewise, if you had this ventilator off and you're going to the same previous patient, you can hit last patient. It pulls up their stuff in their previous settings here, and you can see the mode change. We'll talk about modes a little bit more here in a little bit. A great thing about this is if you know their height or you can approximate their height, you should measure and get it as accurate as possible. You can put that in rather than calculate it yourself. If you have one that shows up, sorry, that glare keeps getting in the way. If you have one that keeps showing up in centimeters for height, there is a way to change that. A configuration tab is the same place where you change all this type stuff. So, this is going to tell us actual mils per kilo when we're making adjustments, monitoring their tidal volume and things like that. If you're using this mode that's populating here, ASV, which we'll talk about in a separate video, it is essential that you have the accurate height and gender, or height and sex for that patient, because the ventilator is actually going to come up with settings based upon those. So it's detrimental to that patient if you have the wrong data in right there, because it's going to influence their settings. Otherwise, we should be thinking about all this stuff anyways, make sure our settings are appropriate. So let's say I got a 70 kilo male, so 70.7, it's going to round up 71. We did the math. Let's talk about pre-op check, okay? So all of our vents, we need to do a pre-op check on that goes by different names, short systems test, SST, things like that. Pre-op check is doing a couple of things. It's ensuring that our ventilator is safe and functional and having no issues, all right? It's also going to ensure that the data that we're getting is accurate. When you think about this tubing itself, it's not made out of a hard material, so as it pressurizes, some of the volume we hope is going to the patient is going to be lost in that circuit compliance. So by doing this test, I'll tell you exactly what specific test, it's going to make sure this vent's ready to roll, and it's going to make sure our values are accurate and everything is working the way it should. So pre-op check, very, very simple to get to here. You can also access this while it's actually on the patient, but it is important to note this patient is not going to be ventilated during all this, okay? So at least these first two that I'm going to show you, you would have to be manually ventilating them over the resuscitator while you're going through all this. So ideally these things are done before, but sometimes some stuff comes up and you're having problems and you might have to pop them off and check this, all right? So we're going to do tightness test first, so I'm going to take off my little swivel here. Tightness is checking this thing for leaks, and if you don't do anything, it's going to go away pretty quickly. Checking this thing for leaks, and that's where it's actually measuring our circuit compliance here, and we're going to make sure that our tidal volumes are actually accurate. So I'm going to go here, I'm going to go to a tightness test. It's going to tell me disconnect patient. Once again, you're not going to have a patient on this, so it's going to tell you tighten patient system. You would do a gloved thumb, not my dirty thumb, all right, or you could use a nice cap that came with your circuit here. It's going to tell us connect patient. It's not, don't connect your patient to this. It means you don't have to have them hooked up anymore. All right, so we get a green check mark. It tells us that we passed. You can see a red X means that you failed here. So in this particular case, a lot of times we're doing this before you're actually going to a patient room, we would at least have some means of making sure that, hey, this was done at this time. Some hospitals are going to have a sticker or a cover that goes over this afterwards, just so the end user knows that this is completed. So tightness test, making sure our exhalation diaphragm's good, our circuit's good, we don't have any leaks, and compensating for that lost circuit or lost volume for circuit compliance. Making sure our values are accurate. If you cannot get this to pass, start with basic, checking your connections and stuff like that. But if all else fails, go back to that exhalation diaphragm. That's usually your culprit there. It's not seated right, or it's not locked in, something like that. Sometimes it can be some other weird, obscure thing with your circuitry, but typically find as somebody messed up on that exhalation valve. The flow sensor here, same, just like all the other Hamilton ones. You are going to need this particular clip. I'm going to remove my HME here real quick, although I probably don't absolutely have to. You're going to need this piece of plastic, because this piece of plastic that comes with that flow sensor, we're trying to calibrate and kind of zero out this flow sensor, and it's trying to mimic gas coming from the ventilator side as well as the patient side. So the way it's hooked up right now easily can, mimic gas coming from the ventilator side, because it is. This piece allows us to put that on the top and flip this thing around when prompted to mimic air coming from the patient side of things. So you can typically start with this piece on. So I'm going to go ahead and go to pre-op check. Flow sensor. It's going to tell me disconnect patient. Once again, this is not ventilating my patient. It's telling me turn flow sensor. That's where if I already have this piece on, it allows me to swiftly turn. If I'm too slow with this, it is going to just jump me out. If you look really, really closely, you can see these little materials moving on the inside, almost imperceivable to the naked eye. It's going to ramp up here. It's going to tell me turn flow sensor again. I'm going to flip over. I don't really need that piece anymore at this point. I don't get rid of this piece. I just clip it over here on the side just in case something happens. Clip it out of the way. Their flow sensors are pretty good, but I still, if I'm running these vents on somebody, I make sure I at least have some in my unit or nearby in case something does happen to your flow sensor. It doesn't last forever. Okay, we passed. We're good. O2 cell. The O2 cell on the CO2. So the CO2 is grayed out because I don't have my capnography module actually inserted here. The O2 cell you actually could do while it's on a patient. There's really no steps to it. I'm going to go ahead and hit it here now because I haven't done it in a little while. It's going to take just a little bit of time here. So what we're going to do next, we're going to talk about basic mode selection. I'm going to fire this up just a couple of modes, all right, and kind of talk about what this vent doesn't have, a little bit about these quick access buttons. Talk about one more little connection that's on the side of this thing that I didn't get to. You can see it takes a little bit of time to do this one, but it's not anything that you're necessarily having to do or anything like that. While that's doing its thing, just kind of show you. The one port we did not talk about right here, it is a adapter for our standard jet neb. So if you're doing a valve T adapter and want to give nebulization, the benefit there is you can run it through the ventilator. You're not adding in any extra flow that the ventilator is getting from some unknown source, and you can deliver it kind of more effective means there without causing problems. I'll show you how to kind of run that once we're up and running. And I already kind of mentioned this, but while we're waiting for this to do this, you only need these fancy little weird elbow pieces whenever you're using this particular transport circuit. If you were just doing a straight up regular dual limb circuit or heated wire or anything like that, you could go ahead and you don't need those. You just make your direct connections just like any other ventilator. So let's see, we're getting close here. Try and move it out of the way of that terrible light fixture giving me my glare. We kind of put it on an angle here. Could have probably skipped this one, but it needed to be done. And it failed. So it could have failed because my ventilator is overdue for preventative maintenance and maybe needs a new sensor. That is okay. It would not be okay for a regular patient, okay? We would pull this to the side. I'm going to show you a little workaround here. I'm going to click out of this. Show you how to get our system sensors. For what we're doing, I'm going to turn off the O2 cell so it's not going to alarm at us or anything like that. So we will be good to go on our pre-op check. Once again, I'd be concerned about the O2. Let's talk about firing this thing up, okay? So let's go ahead and just kind of talk a little bit about mode selection. You might have a different one that has another option, and we'll talk about here in a second. The way that this vent's broken down, you have volume targeted ventilation. So I want to be very, very clear. This particular ventilator does not deliver true volume ventilation. You set a target tidal volume, but it does adjustable pressure ventilation. You'll see a couple of different terms. I have ours set to the kind of standard Hamilton terms, APV, adaptive pressure ventilation, and then we got CMV as your mode selection, and SIMV. So APV, or adaptive pressure ventilation, meaning it's going to adjust the amount of pressure trying to, on a breath-by-breath basis, try and get us to our tidal volume and maintain that tidal volume. So you get some of the benefits of pressure control, but with a little bit more automation as far as trying to reach your tidal volume. There's another way you can change this name around to say SCMV plus. It's confusing because SCMV is typically like set tidal volume or volume ventilation where you're setting a target, an actual tidal volume for delivery. The SCMV plus, that's not a true, it's not true volume ventilation. It's the same thing. So I try and refer to this what it is, and as just as you would change like the inches, from centimeters to inches, or what your defaults are, you would go into the configuration tab. Hang on. you would get into the configuration tab, type in your code, and you would change that from SCMV to plus to APV. I just like it because switch to the APV because it's tried and true. So we got our volume targeted pressure modes. We got straight up pressure ventilation. So controlling pressure is a control variable in traditional sense. That could be, mandatory wise. So like PCMV is typical pressure, continuous mandatory ventilation, pressure assist control. We got pressure SIMV, spontaneous, so pressure support ventilation for the actively breathing patient. And then you got two ways of running inverse ratio pressure control, so duopap or APRV. Duopap is more if you've coming from like the 980 Puritan ventilator series, a little more familiar to you. ASV, so adaptive support ventilation. It's outside of the scope of this video, but it is where you're putting in that ideal body weight and the percentage of their minute ventilation you'd like to target, and it comes up with settings, and I got another video on that. And then non-invasive routes. So I got typical non-invasive, no backup rate. It does have an apnea. You set an apnea alarm for 20 seconds, so you do have backup ventilation, but it's not setting that, those time-triggered breaths to fall back upon if they don't trigger for a moment or anything like that. What you're typically used to, if you're working with V60, some of the other different non-invasive units out there, is non-invasive ST. So that's, you got pressure support for your patient, so baseline pressure, pressure support, and you have a backup rate. Okay. If you have a different software option, you might have high flow, so high flow nasal oxygen through this, and that would be a heated wire system here. So let's go ahead and go to AP. Let's just do pressure control right now. We're not talking about volume ventilation. We haven't talked about APV just yet. That'll come a little bit later on. I'm going to go ahead and hit confirm. So this is regular pressure CMV, so we can put a patient on this and that's not breathing. We're allowing them to get pressure controlled breaths, and they're all time cycles, so we have a set I time, and we would just adjust that pressure up or down. P control, all right, so that's our actual inspiratory pressure we're providing on top of our level of PEEP here. If you don't, obviously we don't know how much pressure it's going to take if we're initiating ventilation on pressure. I typically start somewhere in that 10 to 12 range and then kind of quickly go up looking at my exhale tidal volume. We got a rate here. Everything is kind of touch screen. You can touch, turn, touch here. I can use this wheel to kind of make changes if I don't want to touch the screen. Got a lot of different options. 1 second is typically a pretty good inspiratory time for starting out in pressure ventilation for our patient. Flow trigger of 5 is pretty good for adult patients on this, especially flow sensor being proximal there. I've never had any issues with patients triggering. It shows you your IDE and your amount of E time here. The G5 and some of your other ones will show you a lot more information as you're changing rate and things like that. This one's a little bit more simplistic. If you wanted to hit more, you have the psi feature, which we'll talk about later, and then ramp. Ramp is the same thing as rise, so it's how long we're taking to reach that pressure. Typically 50 milliseconds, 100 milliseconds is pretty good, and we'll learn to refine that with graphics later on. So let me go in. Let's go ahead and start with inspiratory pressure 12, so it's going to give 12 on top of 5 for total pressure of 17. Okay, so it's outside of that IPAP, EPAP stuff we learned in the non-invasive unit. Even if we were going to do non-invasive ventilation on this, you don't have to do that math problem. You set your pressure support, which on this vent is calling it inspiratory pressure, which is true. You're actually setting that in your baseline independently, so no subtraction involved. It's actually giving 15 centimeters of inspiratory support on top of 5 or PEEP. If you adjust your baseline, it's not going to have a negative effect on your inspiratory pressure. You're setting them independent, which is way better. So let's go ahead and restart this at 12. Let's say we got a target tidal volume about 400 mils for our patient. I'd choose whatever FI2 I think is appropriate here. I'm going to go ahead and hit confirm. I am going to hook up to a test lung here, and we're going to do a little start ventilation. Need my elbow. This vent doesn't start up on its own, so you actually do have to make sure you hit start ventilation. It's going to take a second. It's going to keep alarming about my batteries and stuff, which is fine. I'm going to have some alarms going off. Like the other Hamilton vents, if you see down here, it does audibly silence your alarms for that first minute. We know there's going to be a lot of thresholds that are not reached yet. So you can see tidal volume is pretty low here. My particular test lung I have is not very compliant. Let me switch over to my other guy. If we could only change out our patient's lungs so easily in the real world. All right. So you can see my tidal volume is 347. I'm going to pre-silence my alarms again, so I'm going to hit that 2 minute because it's going to keep honking at me. It's telling me low minute volume. I got red. So all I'm going to do, I'm going to go into my alarms here. I'm going to hit auto while we're doing this just so it stops honking at me, and then click out, and then we can kind of refine our alarms afterwards. So my tidal volume is low, so before I get too involved, I need to get up to my target tidal volume of 400 mils. So I'm going to just kind of go up by a couple centimeters at a time on my inspiratory pressure in order to get that to come up here. You can see my minute ventilation to start coming up. And I'm pretty close. So real-time monitoring is over here on the left side, so my peak pressure of 20. So 14 plus 5, I know that's 19, but it's not going to give me a decimal unit for a pressure measurement here, so it's rounding up, which that's totally fine. So we're giving a constant amount of pressure on a breath by breath, and the thing that's going to vary be my patient's tidal volume here. So you can see my minute ventilation is coming up. I'm going to bump up my rate just a little bit, probably be a little bit more appropriate for this guy, depending on what's going on. Peak pressure, expired minute volume, my VTE, so my exhaled tidal volume, was actually coming out of the patient, right? We're measuring exhaled values as we get into invasive ventilation and even non-invasive ventilation on this one with a dual limb circuit. All right. F total is respiratory rate. Okay, so my patient's not going to be triggering breaths. If I hit the controls tab, it's going to show I got a rate of 15. So it's picking up there. It's going to get me there. So at any time, if I wanted to access any of my controls, I can go there where I just did. Monitoring, this can be customized to whatever sequence you like, but you can hit monitoring and pull up a little bit more data. Shows me my VTI, shows me if I got a leak, shows me my I time, E time relations, actual real time. In pressure ventilation, we don't set a flow rate. We're given as much flow as it takes to reach a set pressure, so it does show me what my patient's flow is. All right, hit number 3 here. Tries to do micro pauses and calculate static compliance, time constants and things we'll get into. I'm going to hit alarms again to hit auto. So, a couple other things here. We're not going to talk about alarms. It's showing you that it's saying both my batteries are charged. I don't know why it's giving me the requirement there. You can see batteries, and I'm on AC power. If I disconnect from the wall, it's going to tell me loss of external power. I get an X right there, and it's showing me that I'm running on one of my batteries. Both my batteries are green. These things got a pretty good long battery life. Plug back in. So a couple other things. If I was running the neb feature, I could hook up, I could hit this button, and it's going to give that nebulizer on inspiration, which is ideal. Using a vibrating mesh neb would even be better. We have 100% O2, so if my patient was desaturated, I'm getting ready to suction them, and I wanted to hyperoxygenate, I can hit 100% O2, and it's going to bump them up for 2 minutes, and it'll show you green, we're at the 100%, and it's got a countdown. That should coincide with you having your alarm silence, obviously, right? So I'm hitting that, silencing my alarms before I go down to suction. I could hit that alarm silence again to eliminate that alarm silence, and you shouldn't like leave a room with alarm silence, something bad could happen. I could hit the 100% O2 button again if I was done and wanted to drop back down. You got day and night mode or whatever, right? We don't really change the color sequence a whole lot for what we're doing. One thing I want to kind of point out, and it's not as important on pressure ventilation, is volume, although some people would argue that. But we can't check a plateau pressure on this ventilator. I would assume the rationale is it's all pressure ventilation. So as long as you're proficient at reading these flow waveforms and recognizing what we'll learn later on, that you got total flow equilibration between, or total pressure equilibration between your Y, or the patient connection, and the patient. Because at the end of that breath, we were at a 0 flow point. I could assume that my peak and plateau are pretty close. The good thing about pressure ventilation is we know that our peak pressure can never really be lower than our plateau pressure or anything like that. So just because you got a high peak pressure in pressure ventilation doesn't always signify that your plateau is exactly that way. It requires you being able to interpret that flow waveform. Right now, I'd be pretty certain that this patient is in fact having a plateau pressure is pretty close to the peak, if not exact. This button that everybody thinks does a plateau pressure is actually just a breath hold. It's going to hold that pressure that you have set at the Y, all right, and you're essentially doing a breath hold. So it's always going to end up being whatever your peak is. think Hamilton guys that tell you you could go back and calculate, because this gives me a static compliance value. You could go back and plug that in and do a backwards algebra problem. I personally think that's unnecessary. Being able to interpret your flow waveform and tell if your peak and your plateau are close, which would make more sense later on, and looking at your peak pressure value, I think that should be sufficient, and for you to make informed judgment calls as far as your ventilation strategies go. What else with that? I'm not going to go ahead and set alarms or anything like that. If you wanted to know what was going on or you got called, you can go back and see any changes that were made, any buttons that were hit, and alarms going off and things like that. You can scroll all the way back through. If you needed to retest or calibrate something or make sure it was done, you can access that by going into your systems panel. You can change loudness. You can change a bunch of other stuff, time, date, all these different things through here. But that's good overview of the functionality of this ventilator here. I'm going to go ahead and show you how to put it in standby. So I'm going to go ahead and hit the power button again. Activate standby, so no longer giving gas to the patient. I could leave it in this screen, or I could press and hold this for 3 seconds, and it's going to go ahead and shut off. So that serves as a pretty good overview here of setting this ventilator up, as well as showing you how to really do the pre-use check, in addition to initiating pressure ventilation in a very kind of abridged version there. Okay, we'll spend more time talking about pressure control initiation. But that's a good synopsis of everything. So I hope that helps. As always, just make sure you feel comfortable with the circuitry and finding your way around the ventilator. That's the first important step.